Hello and a very warm welcome to Series 2 of Autism Unpacked. I'm your host, Rosie Gill-Moss, and I'm so pleased to be back with you for another episode where we're going to dive into the many layers of autism, the myths, the challenges, and the lived experiences, all through honest, open conversation. Whether you're a parent, a carer, an educator, or just someone trying to understand a bit more, thank you for being here. Today, we're talking about something that comes up a lot and yet still feels misunderstood and often overlooked: feeding and eating disorders in children, particularly in the context of autism. Now, this isn't just about fussy eating. We're talking about complex and sometimes very distressing challenges that families face every day. To help us unpack this, I'm thrilled to be joined by Natalie Raven Morris, the founder and CEO of the Feeding Trust, an organisation doing incredible work in this space. Natalie not only brings a wealth of professional experience, but also a deep personal passion for helping families navigate the tricky and sometimes downright terrifying world of paediatric feeding and eating disorders. Understanding feeding and eating disorders. Feeding and eating disorders are not rare, but they are often misunderstood. Let's get the conversation going. Hello, Natalie, and welcome to the show. It's lovely to have you here. Tell me a little bit about what your charity does and how you got into it, if you would.
Oh, hello, Rosie. Well, thank you for inviting me to be here today. So I am from the Feeding Trust, as you said. So we are a charity that are relatively new, and we were set up to support children and their families and people around them who have developmental feeding differences and difficulties. So that can kind of span a really wide range, from children who have got differences with the way they're developing their feeding skills, right through to children with quite severe feeding disorders. So I am one of a team of people. We are therapist-led, so we're speech therapists, occupational therapists, dietitians. We've got psychologists kind of behind the scenes as well on the team. And we work directly with families and with children at our feeding clinic, but we also do an awful lot around advocacy and awareness raising, education and training. But we also do research as well, so we're kind of trying to get a foothold into the research field so we can sort of build the evidence base up within the UK.
Specific disorders and their consequences. Disorders can span a wide range of symptoms, so it's useful to differentiate them. Here's the expert view. So, Natalie, your charity specialises in working with children and young people who have feeding difficulties. Now, when we think of eating disorders, we tend to think of anorexia or bulimia. And whilst I know that those will play a part in our conversation, could you talk a little bit about ARFID and explain what the acronym means?
Mm-hmm. So ARFID is avoidant restrictive food intake disorder. So it's quite a mouthful.
Yeah, no wonder you acronymed it.
No wonder you acronymed it. And it sits within the same category as anorexia and bulimia. So it sits within the diagnostic manual for sort of psychological psychiatric conditions. So it does fall under the umbrella of psychiatric conditions. Mm-hmm. But it's very, very different from eating disorders such as anorexia because it's not got anything to do with body image and controlling your weight due to sort of body image issues. So that's sort of the main difference.
Would you say that it presents sooner as well? Are you seeing signs of ARFID in very, very young children?
So it's ARFID is a relatively new diagnosis, so it sort of came around in about 2013. So although that seems like quite a long time ago now, within the world of sort of diagnoses, we're still finding out about it, and we're still finding out about how it develops and the best way to support children and young people and adults with ARFID, because as an eating disorder, ARFID doesn't just sort of go away. It's something that it's as a mental health condition, you learn to live with it for life, like you do with other eating disorders. But what we're certainly seeing is, again, with all eating disorders, they don't come out of nowhere, do they? Everything, where does it come from? So what we tend to see at our charity is you get younger children, so very young children from sort of weaning age, or 3 or 6 months, who really begin to sort of struggle early on due to things like, reflux and constipation, food allergies, tongue tie, that kind of thing. So their journey with learning to eat is really problematic and it's really hard. And sometimes it's physically quite painful.
Right.
If you think about constantly vomiting, constantly, it's acid, that's what you're coming up. So, or you're really, really constipated. You begin to associate eating with pain very, very early on. And even young babies, they're not, their brains are organised in a very, very simple way. And the need to avoid pain will override the need to eat.
Wow, okay.
So biologically, it makes sense, isn't it?
Yeah.
It's in terms of survival, you need to avoid pain before you eat. So babies that are constantly getting a pain signal that this is uncomfortable will learn to avoid it very early on. But what we see is when these feeding difficulties emerge so young, the typical pattern of learning to eat gets really disrupted. So you get a very, very different path of feeding development. So children don't go through these normal developmental stages and everything kind of happens as it should do. Their developmental journey looks very, very different. So by the time they get to about 3, their relationship with food, the skills around food looks very, very different to a child who hasn't had that experience with food growing up. And so what we see is these young children with medical sort of backgrounds or histories, and they skill-based difficulties, you get what we would call sort of nutritional consequences. So they avoid eating, fairly straightforward. But of course, that leads to nutritional consequences. So they can become deficient in vital sort of nutrients and things like iron, for example. Now, iron, it has a key role to play in appetite regulation. Right. So if you're deficient in iron, ironically, one of the first things it does is you don't recognise you're hungry. So you eat less, even less. So you're already struggling with your eating and then you become iron deficient and then you eat even less. So you can see how quickly you can spiral into really quite significant challenges. So what happens is you get these very young children who have got a real physical challenge with learning to eat, and it's physically very, very difficult. And what we see is as these children get older, they kind of get sort of 6, 7 years old, some of those, those early developmental and medical challenges will have they'll have found a way around them. But what you end up with is the psychology around eating becomes very, very problematic, and they begin to have beliefs and thought processes around food, and they begin to worry about it in a much more kind of cognitive way. And they anticipate that this is going to harm me, this is going to make me sick, and they avoid things for psychological reasons then. And that's when you go into the eating disorders territory.
And would that be where you would classify things like safe foods? So a child might, I'm going to use my children as an example here because 2 of mine definitely have, they've not been diagnosed with ARFID, but there's definitely a sensitivity to food.
Yeah.
So things like Nutella on toast, they will eat a lot of that because it's safe. And is that what you're talking about? Things that they know won't upset their tummies, that won't cause any sort of reaction?
There is... there's certainly an element of wanting predictability. And when children go for the same sort of limited or restricted amounts of foods, it's because they want predictability and they know what to expect. So with something like Nutella, a jar of Nutella, every single jar of Nutella that you get off is exactly the same. It never changes. You peel off that top layer of foil and you get this perfect, unblemished layer of chocolate, and you know exactly how it's going to taste, you know exactly how it's going to feel in your mouth, you know how it's going to smell. All of those sensory properties are really, really predictable. Now, you counter that with a packet of strawberries. You peel off that layer of plastic and you delve in, and goodness only knows what you're going to get.
Yeah.
It could be sweet, it could be sour, it could be soft, it could be hard. There could be bits in it. It could be red, it could be white, it could be green. Who knows? It's so unpredictable. So for our children that have got those really, really negative experiences with food, sticking to foods that are very, very same, they're very predictable, and often it is those ultra-processed foods because they are always the same. Actually, it does give them a sense of safety and security because They know they're not going to get any nasty surprises. And whilst it might not, be as pleasurable, we might really enjoy Nutella on toast and it might be a real treat. For them, it's just a bit of actually, well, I know what I'm getting here and it's the lesser of two evils. And so I'd rather go with that.
When it's about more than fussy eating. Next, we learn that picky eating is part of normal development, but it can be worse when your child already has a negative relationship with food. So if you have a parent who's listening now, and one of the very common things that will be said to the parents of a child with ARFID is that they're fussy, that if they were to present the food differently, if they were to go without, they would eat eventually. Now, you and I know that this is very much not the case, but how as a parent could you tell the difference between what is a child perhaps being a bit picky, because we all know they can be,
absolutely,
and a child that has ARFID?
So certainly fussy eating is part of typical development. Most children will go through it, and it certainly aligns with what we call the neophobic stage of development. So neophobia is effectively means fear of new things, and particularly fear of new foods. And it peaks between the ages of 18 months and 3 years old, which is a great time because that also it peaks with those lovely toddler tantrum, sort of years where children are they want to stop, sort of like, strike out and get control over their little world and have things just the way they want it, and they will let you know about it very, very, very clearly. But so with all children, we'll go through this sort of neophobic stage, and it's there for a really good reason, and it's there because if you think what happens between the ages of sort of 18 months and 3 years old is children physically get an awful lot more independent. So they can get up, they can walk around, they can go over to that plant over there and they can think, I wonder what that tastes like.
Of course.
Now that plant might be poisonous, it might have berries on it. So actually it's very, very sensible that they don't go over to random things and put them in their mouth and eat them because it could poison them.
Yeah. So,
but if you think as a parent, how would you learn, or how would your child learn that that's not poisonous?
Try it.
Yeah. You kind of learn through parents kind of go, no, it's okay. It's not poisonous. It's okay. It's okay to eat it. But when you've got a child who has grown up, as we've said, with these sort of pediatric developmental feeding difficulties, and they hit the neophobic stage. Now you've already got a child who's got a very, very negative relationship with food. And they've already got a lot of pain associated with food. And with those children, as I've said, in terms of the brain's priorities, actually trying new foods and eating comes about third or fourth down the pecking order. So first of all, obviously, is breathing. Secondly is avoiding pain. And thirdly, this is a bit of a weird one. This is someone throws people sometimes. It's postural stability. And you think, what on earth? That literally means making sure your head is kind of like, where your head is in space.
Yeah.
So the only way I can kind of explain, not the only way, but one of the ways I can explain it to you is if you go up or down an escalator or you step out of a lift, that feeling, that really weird kind of, or you get off a boat and you're kind of like, oh, where's my head at? You feel really kind of discombobulated. While you've got that feeling in your head, your body is absolutely not going to eat anything. And it's quite a sicky feeling and it's quite an unpleasant feeling. And you think, well, we don't get that very often. That's only because actually as humans, we've got pretty good vestibular systems that tell us exactly where our head is in space. We know with a lot of children with autism, for example, their vestibular system works in very different ways. Gosh, so it's part of the sensory system. Vestibular is one of our senses. So we know we've got the 5 main senses we all know about, but we've also got 3 other sort of internal senses that are really unseen. So vestibular is one of them. Proprioception is the other, and that's the senses we kind of get through our muscles and our joints. Yeah. So if I said to you, without looking, where are your feet right now?
I can feel my feet.
Where are they?
Down there.
On
my legs.
On the end of your legs on the floor?
My legs. I'm worried I'm going to get this question wrong.
I'm going to check.
So one foot's on the floor, one's in the air.
And and do you feel quite secure?
Yes.
You do, because you kind of know you're getting that sensation through your body and you know where your body is in space. Now, a lot of children with autism, actually, their sense of getting that force and pressure through their muscles, like they can be oversensitive and undersensitive in other areas, you can be they can struggle to interpret that information, which is why an awful lot of children with autism really struggle with sitting still. And it's not because they're little fidgety little things and they can't sit still because they can't concentrate. It's because literally they need to move to know where their body is in space. Their brain is telling them, where's your head at? Wow. Where's your head at? And whilst their brain does not know where their head is at, they will be fidgeting, they will be moving, they will be spinning around, they will be moving because they need to find out where their head is and they need to get more and more information to kind of feel comfortable with where their head and where their body is in space. Now, whilst they are in that state, are they going to be eating? No. So that's another thing. And then, so we've got all these priorities that come way before what, the brain's ability to say, okay, I'm ready to eat now. So you've got those 4 main priorities. Now, you could then overlay it with the more psychological aspects, which is where I would do the whole bush tucker trial thing with you. And I would say, Rosie, I am going to put a plate of live grubs on the table there in front of you. And go on, just try one. What would you say?
I'd be so fast out the door.
No, but honestly, they're fine. Honestly, they're not going to hurt you. Just try one.
No.
But they're quite tasty. They taste a bit like
There are no
chicken.
grub. You haven't got any, have you?
But no amount of me coaxing, cajoling you and trying to tell you how delicious and lovely and they're absolutely fine will convince you to eat those grubs. And it's exactly the same with a child with a feeding disorder or an eating disorder, with something like paediatric feeding disorder or ARFID. No amount of you trying to convince them that that's okay to eat will suddenly go, oh, yeah, okay. Well, obviously the last, 5 years of my life, I've just been making it up. It's fine. It's really not that simple and straightforward at all, because they've got all these other things that are overriding them saying, no, danger, avoid, that's going to hurt you. Anything, all these bad things could happen, basically.
And of course, that sort of plays into this idea. And I don't mean to misrepresent the older generation, but often they will say things like, if you leave them long enough, they'll eat. Mm-hmm. They're just being fussy. You're letting them have too much control. Mm-hmm. Back in my day, we didn't have all these choices. And actually, what you're saying, there is real scientific medical reasoning for these children to be fussy. Is there a sort of short, snappy response that parents could use when faced with this sort of scrutiny or disbelief, shall we say?
I think it's a really difficult one for people that don't get it to understand. And I see it myself, and I am well versed in talking about this. Obviously, it's my soapbox. I love talking about all things paediatric feeding disorders and eating disorders. But you will literally see people glazing over in front of you. They just don't get it, and sometimes it doesn't matter how well you try and explain it. They just don't get it. They get things like eating disorders because eating disorders have been around for a long time. Mm-hmm. So if you said, oh, they're anorexic, they understand that. They kind of understand, okay, there's actually a sort of a biological sort of neurological thing going on there that's preventing them from, or that's causing a mental health problem, and they understand that that's a genuine health condition. But they really don't understand it when it comes to learning to eat. So the one thing I've began to sort of say to people is you can say, oh, my child's got paediatric feeding disorder or my child's got ARFID, and still people will just glaze over. But I think sometimes if we try and reframe it and kind of almost not look at it through a medical or a sort of pathology type lens, because people don't see it as a real pathology. They don't see it as a real medical problem. So if we can reframe it and look at it and approach it from a developmental lens, people sometimes understand it a bit better. So I sort of say to people, if your child was 18 months old and you took them to the doctor because they weren't walking yet, in fact, not only were they not walking, they weren't putting to stand yet, they had really poor sitting balance, what would the doctor say to you?
Well, they'd say that there was a slight development delay and perhaps refer them for somebody for some support.
Absolutely. They would say, oh, crikey, okay, they're missing their physical milestones. Let's refer to physiotherapy because there's a service for that. Yeah. It's taken seriously. Same thing with, take that same child, 18 months old, you take them to the doctor and say, they're not talking yet. They're not trying to say any words yet. In fact, they're not using many gestures. They're not kind of pointing to things they want. They're very quiet. What would the doctor say?
Speech therapy.
Absolutely, yeah. Oh, this is a communication delay, speech and language problem. We'll refer you to speech and language therapy. Okay. Same child, 18 months old. I go to the GP and say, I'm really struggling. My baby's really, really struggling with feeding. I've tried weaning and we don't really seem to be getting anywhere. And meal times are a real battle. They're crying all the time. It's really stressful. I've not been able to go back to work yet because I can't get my baby into nursery because they're not, they won't eat. It's really, really difficult. They'll say, pop them on the scales. Pop them on the scales. They look fine to me. Just try harder. Just keep going.
And that's the thing, isn't it? If their weight is stable, there's no alarm symbol.
Yeah, absolutely. But the fact is there is no feeding service. Feeding as developmental domain is not recognised as you've missed key milestones here. But it's like any other developmental domain. All the other developmental domains are taken quite seriously. So if you look at it that way, you think, oh, well, actually, this child should be, at 18 months, they should be, certainly be beginning to feed themselves, and they should be able to sit down and eat a meal and eat what most of the other family are eating by now, even if it might be in a sort of slightly modified format. This should be happening by now. And a lot of children, that it's just simply not happening. They are really, really, really struggling. And the whole weight thing, as you said, is a real red herring, because whilst we know that a lot of these children will be very nutritionally compromised, often their growth is absolutely fine. And that's only because people like yourselves as a mum spend every waking minute trying to get your child to eat something.
Because they will put on weight if they're eating a very bland diet.
Well, or if you're following them around, constantly trying to feed them, or, just trying to get them to have that little bit more, their weight tends to be okay because parents compensate massively. Like I say, mums don't go back to work, for example. Yeah. I say mums as a generic thing, but it often is. It's mums that have taken that time off work and they struggle with getting back to work because their child just won't eat at nursery.
Risks associated with eating difficulties. Restrictive diets will not provide the right amount of nutrition. We're going to hear what the consequences of that might be. And we talked there about the weights and how that's the sort of factor that doctors will look at to see if a child is healthy. But obviously that's not giving a full picture. So what are the real risks of harm to a child that has ARFID?
So I think, if you go to the GP and they put them on the scales and they say their weight is okay, so for example, on our website, we've got like a sort of like a checklist type thing that you can take to the GP. And there are some real significant nutritional markers that you can go to the GP with. And it's things like missing entire food groups. Typically developing children do not miss entire food groups. Now, children with paediatric feeding disorders and ARFID will miss entire food groups, and very often it's the fresh, it's the fresh fruit and vegetable, and often it's the protein as well. Protein is often a real struggle as well, and you can say not only is this diet very, very, it's very, very restricted, but nutritionally it's very incomplete, and we know that actually. We're beginning to see children in clinic with scurvy and things like that. It's nuts, because the difficulty is when you've got a child with these long-standing feeding difficulties, often getting them to take vitamins is very, very difficult. Yeah. So trying to get them to have a gummy or, a syringe of liquid or something, it's either refused point blank, or if you try and get it in, it's vomited back up again. It's really hard to get a lot of these children to take the vitamins. So if you've got a child who's got a very, very restricted diet and they're unable to take any sort of vitamins at all, they are at high risk of nutritional deficiency. So that means that they're going to be, things like iron, things like protein, vital vitamins and minerals for their growth and for their development. But when you've got a child whose diet who is so restrictive and you can't get vitamins in, you can't get medications in often either as well. So these are often, we had a little lad recently who had chickenpox. A lot of children get chickenpox. He had quite a bad case of chickenpox. And actually what he needed was the chickenpox got a little bit infected, so he needed a course of antibiotics.
Can't get it in.
And
of course, that's dangerous.
He ended up in hospital because effectively they started going septic. So he had to be sedated. He was on a drip, really serious medical treatment, because And the parent and the docs were like, "Well, just hold him down to get the medication in." Obviously, this poor, you can imagine how traumatic this is. But of course, what happens is if you hold a child down and force them to take medication and they've got a serious feeding disorder, it will just get vomited back up again because they're not consciously going, "Oh, I don't want that. I just don't want it now. I don't feel like it." It's happening at a real sort of basic sort of brain level where you go into that fight or flight mode, and in that mode you don't have your frontal lobe isn't there kind of going, "Well, what's the sensible thing to do in this situation? Oh, okay, I'll just take it." If you are in fight flight mode, you are literally fighting for your life, and that's what your brain is telling you.
And that's a distressing situation for any child to be in.
Massively distressing for family, and massively distressing for child. So in that situation, what the body does naturally is it evacuates. So it'll come out one end or the other. And that's a natural reaction to being in a fight-flight situation. So these children, they really struggle with the medication as well, and that can have obviously huge consequences.
Impact on the family. Feeding your child is one of the key roles that a parent fulfills. And when you can't, then it can be traumatic, as we hear now. And I suppose on the sort of other end of the scale, if a child isn't getting their nutritional needs met, it's going to have an impact on their ability to concentrate, on their energy levels, on their mood. So all of these things will be having an impact not only on the child or the young person, but on the family around them as well. So meal times can become a minefield. They can become emotional warfare. Parents could end up cooking, and I speak for myself here, could end up cooking 4 or 5 separate dinners every evening. So even when you're talking about a relatively minor impact compared to the stories you've just mentioned, it is going to be having an impact on the whole family.
Yeah, and I think, you've done yourself a disservice there to say relatively minor impact, because it's not. It isn't. The families that we meet, your one key role as a parent is to feed your child. And if you can't do that,
the guilt,
it's heartbreaking, absolutely heartbreaking. And it affects everything. And it's massive. It's so traumatic for the family. It's so traumatic for the child. And we talk about actually when you have this trauma relationship with food, that does certainly tip into mental health territory later down the line. And that does then, for parents, we see parents having mental health breakdowns and all sorts. And for the children that turn up into the young people, they do end up going into the eating disorder categories because you can see that trauma relationship with food morphs into a real belief about themselves and how they define themselves. And it becomes something that's just such a defining aspect of them. It really causes massive problems.
And I think as well, we touched a little bit about the parents and the carers and about the guilt. And I'm saying mum guilt because I'm a mum, but let's call it parental guilt around food, because we live in a society that's obsessed with food. We have access to nutritional advice all over the place, and we know what we should feed our children. And so if you are giving your child processed sugars, you're giving them food that isn't doing them any sort of nutritional value, but they have to eat, it's very difficult to not feel like you're being scrutinised by other people and judged. And we all know that the mum world can be quite judgmental anyway. And I've seen it myself and with my children and with friends, that you stop going out for meals because you don't know if there'll be something that your child can eat without having a meltdown. Now, have you got any advice for parents who are going through that?
There is so much noise out there, so much social media noise, and that what you'll see is all these perfect families with these children that eat all these sushi and quinoa and whatever it might be, and that's everywhere, isn't it? So and you're right that there's so much judgment. There is so much judgment out there, and there's a lot of scary stuff out there about ultra processed food and the harm it can do for you. But, at the end of the day, we say, certainly our charity, we say food is just food. And all food has got some nutritional value. And even a packet of Haribos, there's calories in there, quite frankly, and, if you've got a child who needs those calories, then, absolutely.
You've just got to get the calories in.
We get the calories in. Yeah, we do. But I think certainly working with, we work quite closely at our charity with Birmingham Eating Disorder Services. So we support the younger age group, and as they get older, they'll transition into the sort of the eating disorder services, because a lot of eating disorder services don't really offer support until children get to about, I would say youngest 8, but generally speaking it's called 10 or 12. And that's because eating disorders, like I said, as a sort of mental health problem, they work very much on cognitions and thought processes around food. So you're looking at CBT type approaches. Now, clearly, if you've got a child who's a 4-year-old non-speaking autistic child, they're not going to be accessing CBT. So your eating disorder services aren't going to be able to help them. What you're going to need is you're going to want your occupational therapy to support around the sensory processing and the self-help skills and things. You're going to need a dietitian, speech and language therapist, bits and pieces.
Getting the calories and nutrients needed. Supplements are a good way to help your child. Listen in as we find out how they can be the safety blanket of the feeding regime. And actually, you've mentioned supplements. Now, I know that some children won't be able to take gummies or vitamins, but if you have a child that does, is this a valid way of getting the extra nutrition into them?
Absolutely, absolutely. Bearing in mind there's no judgment about children, for example, with a child with cerebral palsy that has to have nasogastric tube or a gastrostomy feed because they can't physically feed orally. So they have to have, and all of their feed is a supplement, that is complete nutritional feed. So what's good enough for one child is good enough for another. So absolutely, supplements have got a great place. And if your child will accept a supplement, that provides a really great safety blanket, because obviously there's calories, but there's nutrients in there as well. So certainly trying to get some nutritional advice from a dietitian, if you can, it's really, really advisable. I know there's quite a lot of stuff going on out there about patches and stuff at the moment. You can get vitamin patches.
Okay.
So people are sort of saying, that's fine. If you've got ARFID, just put a vitamin patch on them. The evidence base isn't there yet for vitamin patches, and certainly I'm not the dietitian in the room, but I know our dietitian is very, very, the evidence base is absolutely not there with the vitamin patches, because vitamins can't be absorbed through the skin. So at the moment, they seem like a bit of a fix-all, but there's
potential, perhaps.
There's potential there in the future, but the evidence base is not there yet to support the use of patches.
And I don't know if you can answer this one off the top of your head, but what would you, if a parent is thinking, right, I'm going to get some vitamins, what vitamins should they be looking for? Can you advise on that?
Well, there are good multivitamins. You want
something with iron.
Something with iron, good multivitamin. And I think the one thing we would always say is don't ever try and sneak it into your child's food, whatever you do.
Because you break the trust.
Because our children often are, we've talked about their sensory sensitivities and the fact that they might be hypervigilant to changes in taste or texture. Now, of course, if you put vitamin drops in,
it changes
it. So what you then risk is, if you've got a child that only eats 5 foods, and you've contaminated one with vitamins,
you've got 4 foods.
You've got 4 foods. You're in an even worse situation. So never, ever try and sneak, be it blended carrots or whatever it might be. We've all been there. Blended carrots or vitamins into your child's food. We would always, if you can try and treat it like a medicine, so your child understands this is something like teeth brushing or medicine, it's something that will have to be done. Don't like it particularly, but actually it's just once a day, quick, but be open and honest about it. Don't try and hide it. But also, there's a lot we can do to support children in terms of gradual sort of acceptance and understanding of what it is. So rather than going straight in and going, let's go for a full syringe, we can gradually introduce it so that children begin to actually learn that it's nothing to be worried about, and actually it's okay. So we do a lot of work at the charity where we will provide, and it's the same principle with food really. You'll provide the opportunity to learn about that food or that medicine or whatever it might be, or vitamin, but without the expectation you actually have to eat it.
So you sort of explain to the child why it's beneficial, what it will do for them in a positive way?
Sometimes, but I mean, a lot of our children that would make no difference to. I don't care, quite frankly. That's your priority, that's not mine.
How organisations like the Feeding Trust can help. The Feeding Trust supports people across the UK, and now its CEO Natalie tells us why she feels that's so important. So Natalie, you founded the Feeding Trust, didn't you, and are now the CEO. What brought you to that world?
It's quite a long journey, actually, Rosie.
We've got time.
So I'm a speech and language therapist by background. So I worked with children, special schools and bits and pieces for years. And part of my job as a speech and language therapist was working with children with feeding and swallowing problems. So what I found was, as a speech and language therapist, I would go in and I would do assessments and have a look. And if they could actually swallow safely, a child could swallow safely, then basically I'd have to turn around and say, sorry, they're fine, basically. That physically they can swallow safely. So I can't do any more for you. And you'd be left with these parents who are like, well, I know they can physically swallow safely because if you give them a glass of water or something, they can drink it and they can swallow safely. But every time I try and give them a new food, they're gagging, they're vomiting, they're getting really upset at the table. And I'm like, I'm really sorry. And after how many years of this, I was like, I can't do this, and I can't keep on saying no. Cannot keep on saying no to people. So I left the NHS years ago now, probably about 15 years ago, and I just set up an independent practice. And there was myself, an occupational therapy colleague called Lucy Bates, and a dietitian colleague called Lucy Upton, and we set up a small feeding clinic. And we did this on a very, very small scale. And what we found was it was great. It was really, really rewarding. But we were so conscious of the fact that we would get inquiry after inquiry after inquiry. But of course, it was a privately funded service. And so the only people that can actually afford to pay, even though we were sort of running on the breadline, are families that had those funds available.
So you're automatically, there's a hole.
There's a massive hole. And we the more you do something, the more you realise how much of a problem it is out there. So I actually, I set up a not-for-profit community interest company in 2019. And as soon as we set up on a not-for-profit basis, we started getting referrals from all around the country, and GPs were referring into us, and it suddenly kind of ballooned. And at that point, I think I realised we can't do this as a little kind of community interest company, because people were saying, oh, can you open a clinic in Manchester? Can you open a clinic in Newcastle, in London, wherever? And I thought, well, no, that's not the answer. The answer is actually the NHS need to step up their game. And actually, this needs to be recognised as a problem, and there needs to be a service out there for everyone, not just a few people that can kind of come to see us. So that kind of then evolved, and it took a few years to kind of jump through all the charity commission hoops, et cetera, and we transitioned to become a charity back in 2023. And since then, we've been able to do a lot more around advocacy and awareness raising and education and training. So this last year and up until May this year, we've done a really, really big project called the Paediatric Feeding Disorder Community of Participation, so PFD-COP.
So that rolls off the tongue as well.
PFD-COP for short. But basically that was bringing together health professionals, teachers from special schools, parents, academics, educators, a whole load of people, basically to talk about what we're talking about here today, really, the challenges of feeding difficulties and feeding disorders and eating disorders, and the lack of support, and what needs to change, and how, as a group of people, we can try and sort of influence things around the country, really, to improve the landscape for children, young people and families affected by feeding challenges.
Thank you, Natalie, and thank you for listening today. That brings this part of the conversation to an end. However, I will be back with you soon to talk more about paediatric feeding and eating disorders, how to get a diagnosis, and how to access support. But from me, it's goodbye for now.